So moving on with talk about cyanotic defects, the next defect I'll talk about is tetralogy of Fallot. Tetralogy of Fallot is caused by the anterior deviation of the infundibulum, which is a structure that separates the aorta from pulmonary artery. When this infundibulum shifts anteriorly, it opens up the VSD, a ventricular septal defect, and also it pulls the aorta over the VSD, therefore creating an aortic override. So aortic override means that when the blood goes through the VSD, it goes straight into the aorta. Okay, so there's a VSD, aortic override, and also the anterior deviation of the infundibulum narrows the pulmonary artery. So the opening of the pulmonary artery is narrowed. In other words, you get pulmonary stenosis, and for that reason, the right ventricle, it's more difficult for the right ventricle to push blood into the pulmonary artery. So you get right ventricular hypertrophy. So there's 4 defects associated with tetralogy of Fallot: VSD, aortic override, pulmonary stenosis, right ventricular hypertrophy. Now, the severity of tetralogy of Fallot depends on the severity of pulmonary stenosis, which in turn depends on how much anteriorly the infundibulum is deviated. So if the anterior deviation of the infundibulum is only mild, then the pulmonary stenosis will not be too severe. In other words, the right ventricle can continue to pump easily into the pulmonary artery. And for that reason, majority of blood that's going to go through the VSD is going to be from the left ventricle, because the left ventricle pressure is normally greater than the right ventricle. So you primarily get oxygenated blood going through the VSD and into aorta. So this is called pink tetralogy. However, if the anterior deviation of the infundibulum is more severe, in other words, you get a more severe pulmonary stenosis, then you can see that the right ventricle begins to hypertrophy, its pressure begins to rise, and when its pressure is greater than the left ventricle, it starts pushing that deoxygenated blood through the VSD and into the aorta. In other words, you're getting a right to left shift, and therefore both deoxygenated and oxygenated blood is going to the aorta. Mixed blood goes to the body, and therefore you have cyanotic tetralogy. So in the most severe case of tetralogy of Fallot, you have what is called a pulmonary atresia. In pulmonary atresia, basically means that the pulmonary valve is completely closed or is absent. In this case, you can see that there's absolutely no blood that is able to go from the right ventricle to the lungs. So in order to keep blood flow to the lungs, when the child is born, you have to keep the child on prostaglandin medication, and that prostaglandin will help keep the ductus arteriosus open, and that will allow the mixed blood going into the aorta, some of it to go back down through the ductus arteriosus to the pulmonary arteries, go to the lung, get oxygenated, and return to the left side of the heart. And then when surgery is ready, the surgery might involve creating a BT shunt, and in that basically you're creating a shunt going from one of the branches of the aorta to the pulmonary artery, and that way now you can close the ductus arteriosus, and this shunt, this BT shunt, acts just like that ductus arteriosus, allows mixed blood from the aorta, some of it to go back down into the pulmonary artery, to the lungs, get oxygenated, and return to the heart. But that is not the cure for tetralogy, or what is the best repair for tetralogy, which is going to be done also, is to completely close the VSD and then open this right ventricular outflow tract, so that now you separate the left and right sides of the heart, and you open the right ventricular outflow tract so that the right ventricle can pump easily into the lungs. And that is called primary repair. So the next cyanotic defect I'll talk about is called total anomalous pulmonary venous connection. And what you have in this condition is you have pulmonary veins which normally drain into the left atrium, instead drain into the right atrium. So the right side of the heart receives not only venous blood from the superior inferior vena cava, but also oxygenated blood from the lungs as well. So the right side of the heart is greatly enlarged, whereas the left side of the heart is very small, because all of the blood comes into the right side of the heart. Total anomalous pulmonary venous connection is always associated with an ASD, in other words, a hole in the interatrial septum. And this is very important because you can see, because all of the blood is stuck on the right side, you need to get it somehow to the left side of the heart so it can be pushed to the body. And that is why you have the ASD. So ASD allows the mixed blood, deoxygenated plus oxygenated from the lungs, from the right atrium to shunt to the left atrium, and then to the left ventricle and out to the body. So to correct this defect, the surgeon would have to close the ASD and reconnect these pulmonary veins directly into the left atrium. Okay, so it makes sense because by closing ASD you prevent the right to left shunting, and by connecting these pulmonary veins into the left atrium, you allow oxygenated blood to return only to the left side of the heart. So the last type of cyanotic defect I'll be talking about in this tutorial is called tricuspid atresia. And tricuspid atresia means that there is no tricuspid valve, which is the valve that separates the right atrium from the right ventricle. And for this reason, all deoxygenated blood coming into the right atrium is shunted through an ASD into the left atrium. So in this condition, all of the blood, both oxygenated and deoxygenated, is going into the left side of the heart, which is then pumped to the rest of the body. So the left side of the heart is greatly enlarged, whereas the right side of the heart, the right ventricle, is very small. And you can see this is exact opposite of what I talked previously about total anomalous pulmonary venous connection, in which all of the blood returned to the right side of the heart, so the right side of the heart was enlarged, whereas the left side of the heart was small. Tricuspid atresia defect can come in different forms. It may be associated with a normal pulmonary artery, with pulmonary stenosis, or even with pulmonary atresia. Furthermore, it may or may not be associated with a VSD, and there may or may not be a detransposition, in other words, a switch between the aorta and pulmonary artery. Okay, so there's different types of tricuspid atresias depending on which other defects it's associated with. If tricuspid atresia is present together with a pulmonary stenosis, what you would do is when the child is born, you wait and see if the oxygen saturation is normal, because maybe the stenosis is not too severe and you can maintain blood flow to the lungs. If oxygen saturations begin to drop,